Hello friends, welcome to my YouTube channel. In this video, I will discuss the key points of gastrointestinal bleeding in infants and children. Now first of all, how do the causes of lower gastrointestinal bleeding vary by age group? In newborn and infant, common mucosal causes are peptic ulcer disease, necrotizing enterocolitis, infectious colitis, eosinophilic or allergic colitis, Hirschsprung enterocolitis or anal fissure, and the structural causes are intestinal duplication, Meckel diverticulum or intussusception. In a child, common mucosal causes are anal fissure, juvenile polyp, infectious colitis, inflammatory bowel disease, solitary rectal ulcer or lymphonodular hyperplasia. Structural causes include intestinal duplication, Meckel's diverticulum, intussusception, volvulus, Dieulafoy malformation in which a large tortuous arteriole is present in the stomach which erode and bleeds. Other causes include hemolytic uremic syndrome, Hinoch-Schönlein-Purpura, Munchausen syndrome by proxy, arteriovenous malformation or vascular malformation. Now, how do the causes of upper gastrointestinal bleeding vary by age group? In newborn, the common causes are swallowed maternal blood, vitamin K deficiency, stress gastritis or ulcer, vascular anomaly, coagulopathy, or milk protein sensitivity. In infants, common causes are stress gastritis or ulcer, acid peptic disease, Mallory-Weiss tear, vascular anomalies, GI duplication, gastritis or esophageal varices, duodenal or gastric web, or bowel obstruction. In children, common causes of upper GI bleeding include Mallory-Weiss tear, acid peptic disease, esophageal varices, caustic ingestion, vasculitis, tumor, or hemophilia. What features on physical examination can help identify an unknown cause of gastrointestinal bleeding? Now on skin, look for the signs of chronic liver disease, for example spider angiomas, venous distension, caput medusae or jaundice. Signs of coagulopathy, for example petechiae or purpura. Signs of vascular dysplasias, for example telangiectasia or hemangiomas. Signs of vasculitis, for example palpable purpura on legs and buttocks suggest Hinoch-Schönlein-Purpura. Also look for the dermatological manifestation of inflammatory bowel disease, for example erythema nodosum or pyoderma gangrenosum. Now head and neck examination should include signs of epistaxis, especially before placing a nasogastric tube which can induce bleeding. Hyperpigmented spots on lips and gums suggest Peutz-Jeghers syndrome, which is associated with multiple intestinal polyps. Lesion on the buccal mucosa suggests trauma. Webbed neck suggests Turner syndrome, which is associated with gastrointestinal vascular malformation and inflammatory bowel disease. Now, chest and lung examination may rule out hemoptysis, which may be present in tuberculosis or pulmonary hemosiderosis. Cardiac examination should also be done in case of older children because cardiac murmur of aortic stenosis in adults is associated with vascular malformation of the ascending colon, although this association is not certain in children. Now, abdominal examination. Splenomegaly or hepatomegaly suggest portal hypertension and possible esophageal varices. Ascites suggest chronic liver disease and possible varices. Palpable or tender loops of intestine may suggest inflammatory bowel disease. Now, perianal examination is also important because perianal ulceration and skin tags may suggest inflammatory bowel disease. Perianal abscess may suggest inflammatory bowel disease, chronic granulomatous disease, or immunodeficiency. Anal fissures may suggest constipation. Hemorrhoids suggest constipation or portal hypertension. Now, joint examination is also important. Arthritis may be present in case of Hinoch-Schönlein-Purpura or inflammatory bowel disease. Digital rectal examination is also important. A rectal mass may suggest polyp. Growth of the child also give clues. For example, failure to thrive is present in case of inflammatory bowel disease, Hirschsprung disease or other chronic illness. Now an important question. In acute gastrointestinal bleeding, how may vital signs indicate extent of volume depletion? It is important to remember that when acute bleeding occurs in children, it may take 12 to 72 hours for full equilibration of a patient hemoglobin. Thus, hemoglobin measurement is a much less reliable indicator of volume depletion than the vital signs during this assessment of acute gastrointestinal bleeding. Vital signs and the blood volume loss. Tachycardia without orthostasis, that is orthostatic hypotension, is equal to 5 to 10% blood loss. In case of orthostatic changes, that is pulse increase by 20 beats per minute and blood pressure decrease by 10 mm of mercury, then this is equal to more than 10% blood loss. If there is hypotension and resting tachycardia, this means there is 30% blood loss. And if pulses are non-palpable, it means there is more than 40% blood loss. Now the question, how does type of bloody stool help pinpoint location of a gastrointestinal bleed? Hematochezia is the bright red blood. Normal stool spotting on the toilet tissue likely suggests distal bleeding. For example, anal fissure, juvenile polyp, mucus or diarrheal stool, especially if painful, indicate left-sided or diffuse colitis. Second is melena, that is black tarry stools. This indicates blood denatured by acid and usually implies a lesion likely before ligament of Treves. However, melena can be seen in patients with Meckel's diverticulum as a result of denaturation by the anomalous gastric mucosa. Third important type of bloody stool is currant jelly, that is dark maroon stools. This usually come from distal ileum or colon and often are associated with ischemia, for example in case of intussusception. Question number 6. What are the 7 most common causes of massive gastrointestinal bleeding in children? These are esophageal varices, Meckel diverticulum, hemorrhagic gastritis, Crohn's disease with ileal ulcer, peptic ulcer mainly duodenal, arteriovenous malformation, and button battery ingestion, especially in toddlers. Question 7. What are the 2 most common causes of painless rectal bleeding in children? These are juvenile polyp and Meckel diverticulum. Question number 8. What is the simplest way of differentiating upper GI from lower GI bleeding? Answer is nasogastric lavage. After insertion of a nasogastric tube, 3 to 5 ml per kg of normal saline is instilled. If bright red blood or coffee ground like material is aspirated, then the test is positive. Upper GI bleeding occurs proximal to the ligament of Treves. If lavage is negative, it is unlikely that the bleeding is above this ligament, and this rules out gastric, esophageal or nasal sources. However, bleeding from duodenal ulcers and duodenal duplications may sometimes be missed by these aspirates. Question number 9. What can cause false negative and false positive result when stool is tested for blood? False negatives are ingestion of large doses of ascorbic acid, delayed transit time or bacterial overgrowth, allowing the bacteria to degrade the hemoglobin to porphyrin. False positive results are due to recent ingestion of red meat or peroxidase containing fruits and vegetables, for example broccoli, radish, cauliflower, cantaloupes or turnips. Now, what is the initial laboratory workup for GI bleeding in children? This includes complete blood count and hemoglobin concentration. There may be anemia or thrombocytopenia, or there may be leukocytosis or increased bands in case of infection. Peripheral smear may show low MCV plus anemia in case of chronic GI loss, and this warrants iron studies. Prothrombin time may be elevated in case of coagulopathy or liver dysfunction. Similarly, partial thromboplastin time may also be elevated in liver dysfunction and also in hemophilia. Complete liver profile should be done if there is variceal bleeding. ESR and CRP may be raised in case of inflammatory bowel disease. Blood urea nitrogen and creatinine are raised in case of hemolytic uremic syndrome. Stool examination should be done for occult blood. Stool culture and Clostridium difficile toxin assay are useful in infectious colitis or pseudomembranous colitis. In gastric aspirate, blood confirms bleeding site proximal to the ligament of Treves. In gastritis or peptic ulcer, Helicobacter pylori is detected using serum immunoglobulin G levels, rapid urease testing, or mucosal biopsy. Esophagogastroduodenoscopy can determine source of upper GI bleeding in 90% of cases when done in first 24 hours. And colonoscopy identify causes of bleeding in 80% of children with lower GI bleeding. What imaging studies are helpful in assessing GI bleeding in children? In infants with acute onset of bloody stool, plain X-ray of the abdomen are helpful in assessing for pneumatosis intestinalis or signs of obstruction. Imaging for non-emergency pediatric GI bleeding may begin with barium contrast studies, including barium swallows, upper GI series, small bowel follow-through, or barium enema, to point to foreign bodies, esophagitis, inflammatory bowel disease, or polyps. Now, for neonates with malrotation or mid-cut volvulus, oral contrast studies may reveal a corkscrew of small bowel or a bird's beak. In case of intersusception, ultrasonography may reveal target or pseudo-kidney sign. In this case, barium, saline, or pneumatic enema are both diagnostic and therapeutic. Painless large volume bleeding may promote performance of technetium per technetate nuclear scan to assess for Meckel's diverticulum. CT scan of abdomen with oral or IV contrast may be indicated to look for structural and inflammatory causes of bleeding. CT angiography is also a useful tool in cases of lower GI bleeding in children. Persistent bleeding without a clear source may prompt consideration of a radioisotope tagged RBC scan with technetium sulfur chloride. Arteriography assists in localizing the source and embolizing the feeding vessels. Now, wireless capsule endoscopy is under investigation for children. Thanks for watching this video. Please like, share, comment and subscribe to my YouTube channel.